Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing an anatomy topic, and that is anatomy of the thyroid gland. You can also now purchase my notes. I have added links in the description. Okay, so let's get started with our topic. Now, thyroid gland is actually a very highly vascular ductless gland, and it has some unique features which I'll be discussing in a little bit. But before that, let's know what is the location of the thyroid gland. So the gland, if you see in the image over here, it lies opposite to the at the vertebral level of C5, C6, C7 and T1 vertebrae, and it encloses the upper part of the trachea. As you can see, this is the trachea over here, and you can see the thyroid gland enclosing the upper part of the trachea. So each lobe basically extends from the middle of the thyroid cartilage, which you can see over here. This is the middle of the thyroid cartilage, to about fourth or the fifth tracheal ring over here. Whereas the isthmus extends from the second to the fourth tracheal ring. So that is the location of the thyroid gland, both the lobe and the isthmus. Now, the thyroid gland, we can see that there are two parts of thyroid gland. It has two lateral lobes. These are the lateral lobes, and it has an isthmus which is connecting them in the midline. Now, each of this lobe, as you can see in the image over here, it is pear-shaped, and it has specific dimensions, which is 5 centimeter in length, 3 centimeter, 5 centimeter in length, 3 centimeter in width, and anteroposteriorly, or the depth, is 1.5 centimeter. And each of the, on average, the gland weighs about 20 to 25 gram in adults. This gland is actually seen to be a little bit larger in females than in males. An increase in size is seen during especially hormonal phases like menstruation and pregnancy. So first, let's talk about what is the covering of the thyroid gland. Okay, before that, I was telling you about the three unique features of thyroid gland. So amongst all the endocrine glands that we know, thyroid is unique in the way that it not only manufactures its own hormones, it also stores them and then also releases them for use as required. No other endocrine gland has the same feature. Secondly, this is also the only endocrine gland that depends on the external environment for raw materials to make its hormones. And thirdly, this gland is one of the richest blood flow amongst all glands in the body. So these are the three unique features of the thyroid gland. Okay, now let's discuss about the covering of the thyroid gland, or the capsule. Now, the thyroid gland is enclosed by two different capsules. But one is known as the true capsule, and the second one is the false capsule. Now, what is true capsule? True capsule is the one which is formed by the peripheral condensation of the fibrous stroma of the gland, whereas the false capsule is actually derived from the splitting of the pretracheal fascia. You can see in the image over here, this is the true capsule and this is the false capsule. So the true capsule, as you can see, is formed by the peripheral condensation of the fibrous stroma of the gland, whereas false capsule is more of a derivation from the pretracheal fascia. Now, this false capsule is not constantly uniform everywhere. It is seen to be thin along the posterior border of the lateral lobe. So, because it is thin over here, sometimes what may happen is a thyroid tumor can end up extending backwards and compress upon the adjacent structure without a visible swelling in front. So, because the false capsule is thin, it gives any kind of tumor more space to expand posteriorly because it is so loose and lax in the posterior part. So, sometimes this thyroid tumor will not have a visible swelling in the front. And this false capsule is thick on the medial surface of the lateral lobe. So if we trace the pretracheal fascia which is forming the false capsule, what will we find? So if we trace it above, we'll find that if you see in the image over here, this is a thyroid gland, and the green thing that you see is the false capsule which is formed by the pretracheal fascia. Now, if we trace it upwards, we see it gets attached to first the hyoid bone in the middle. You can see this is the hyoid bone. And secondly, it gets attached to the oblique line of the thyroid cartilage on each side. So that is what happens when you trace the pretracheal fascia above. Now, if we trace it below, what happens is it enters the thorax and it blends with the apex of the fibrous pericardium. So now we know about these two different fascia. Now we also need to know what is present in between these two different fascia. So in between the true and the false capsule, we find the presence of parathyroid glands along the posterior border of the lateral lobe. So in between the true and false capsule lies the parathyroid glands. Whereas this is a very common question asked in anatomy in MBBS. Uh, in contrast to the prostate gland, in this case, in thyroid gland, we see that the venous plexus actually lies deep to the true capsule. If you see in the image here, we can see this is the true capsule, and we can see that these venous plexus that we are able to see, it lies deep to the true capsule. Now, what is the clinical importance of this fact? The clinical importance of the fact that when you are doing a thyroidectomy, we remove the thyroid along with its true capsule so as to avoid any kind of bleeding, excessive bleeding from this venous plexus. So, what have we learned now? There are two capsules of thyroid gland. One is a true capsule and one is false capsule. True capsule is formed by the peripheral condensation of the fibrous stroma of the gland itself. False capsule is derived from pretracheal fascia. Now, in between the true and the false capsule lies the parathyroid gland, and deep to the true capsule within the substance of the thyroid gland, within the true capsule lies the venous plexus of the thyroid gland. So this was about the capsule of the thyroid gland. Now let's talk about a structure which is known as Berry's ligament. Now Berry's ligament is a topic that you can actually end up getting a short note about. So what is Berry's ligament and what is the other name of Berry's ligament? So Berry's ligament is also known as suspensory ligament of the thyroid gland. This is actually a thickening of the pretracheal fascia that firmly attaches the posteromedial surface of each thyroid lobe to the cricoid cartilage and the upper tracheal rings. If you see in the image over here, this is the Berry's ligament that we are seeing. This is our Berry's ligament. So you can see how it is attaching to the posteromedial surface of the thyroid lobe, and then it connects to the cricoid cartilage and the upper tracheal ring. Now, what is the clinical importance of this Berry's ligament? Because of the attachment of the thyroid gland to the cricoid cartilage and the upper tracheal ring with the help of Berry's ligament, this attachment is how you can explain when we get before that why a thyroid gland moves up and down with swallowing. Now, this particular feature is so important because whenever you get any case with a mass in the neck, one of the very key features that you check while examining the patient is you ask the patient to swallow and you see whether the swelling is moving while swallowing or not. That means, in case the swelling is moving with the swallowing movement, in that case, it indicates that this is probably a swelling of the thyroid gland. So why is it moving with swallowing? Now the thyroid gland, it is attached by the Berry's ligament to the cricoid cartilage and the upper tracheal ring. So when we swallow, the larynx and trachea actually elevates to help close the airway and direct the food into the esophagus. So because the thyroid is attached to them by Berry's ligament, that will also move up with the swallowing. And as soon as the swallowing is complete, it will return back to its position. So this is a very, very, very important feature which helps you in understanding why the thyroid glands move up and down with deglutition and why any neck mass which is arising from the thyroid gland will move up and down with deglutition. Now, coming to the next point, the next clinical significance is that the recurrent laryngeal nerve passes deep or through the ligament sometimes, and even small branches of the inferior thyroid artery They lie close to the ligament and bleed during surgery. So, extreme care is required to control the bleeding over here so as to avoid any injury to recurrent laryngeal nerve or its branches. So, we have to be very careful during surgery in this area. Last of all, this ligament, Berry's ligament, sometimes can contain a small amount of thyroid tissue. So, when you're performing a thyroidectomy, sometimes this part can be left behind, and this can be responsible for radionuclide uptake in the thyroid bed. This is also responsible for increased thyroglobulin levels even after performing thyroidectomy in a case of a thyroid cancer. So, these are the clinical importance of Berry's ligament. Now, let's talk about the different parts of thyroid gland. So the thyroid gland consists of two lateral lobes. You can see these are the two lateral lobes, and it has an isthmus in the midline which is connecting the two lateral lobes. Now each of these lobes are actually roughly looking pyramidal shaped, and the parts of it is the apex, base. It has three surfaces: anterolateral, medial and posterolateral, and two borders which is anterior and posterior. So let's discuss each one of them and what are the relations of each of these borders, surfaces, and parts. First, let's talk about the apex. The apex is directed upwards and laterally towards the oblique line of the thyroid cartilage. If you see in the image over here, you're able to see a outline of the lateral lobe. You can see how this is the apex, which is directed upwards and laterally, and it lies in between the inferior constrictor muscle medially and sternothyroid laterally. You can see in the second image over here, this is the inferior constrictor muscle and this is the sternothyroid muscle. You can see how the apex lies sandwiched in between these two muscles. Because of this reason, it being sandwiched between these two muscles, any thyroid enlargement cannot extend above this point because of the attachment of the muscles to the thyroid cartilage. Now, secondly, the second relation over here with the apex is that the superior thyroid artery and the external laryngeal nerve, they diverge from each other very close to the upper pole or the apex. The artery lies superficial and the nerve pains deep to the apex. So, if see in the image over here, this is the superior thyroid artery and this is the external laryngeal nerve. Both of them are related to the apex of the lateral lobe of the thyroid gland. Now, the importance of knowing this is when you are performing thyroidectomy, you have to ligate the superior thyroid artery. So, where will you ligate the superior thyroid artery without injuring the external laryngeal nerve, which is so much in close proximity to it? So, in this case, the ligature is applied close to the gland in order to avoid injury to the nerve. Why? That is because the superior thyroid artery lies superficial to the thyroid gland, whereas deep to the apex lies the nerve. So, that is why you should be putting a ligature very close to the gland in order to avoid any injury to the nerve. So, this was about the apex and its relation. Next, let's talk about the base. The base extends to about 5th or the 6th tracheal ring, and the base is related to a loop of the inferior thyroid artery and the recurrent laryngeal nerve. Now, the nerve and artery has very variable relation over here. Sometimes the nerve passes in front or behind the artery, and sometimes it can even pass in between the divisions of the artery. Now, the importance of knowing this relation is again in thyroidectomy, you have to ligate the inferior thyroid artery. So, where will you ligate the inferior thyroid artery? Now, in this case, the ligature should be given away from the gland so as to avoid injury of the nerve. So, the apex is related to the superior thyroid artery and external laryngeal nerve, and the base is related to inferior thyroid artery and recurrent laryngeal nerve. Next, coming to the anterolateral surface or the superficial surface. So, you can see that this purple colored structure over here, this is the gland. This is the anterolateral surface that I have marked here. Now, the anterolateral surface is overlapped from within outwards. So, from within outwards by the following muscles. The first muscle is the sternothyroid muscle. Next comes the sternohyoid and the superior belly of omohyoid. And last of all, a part of sternocleidomastoid also overlaps it. So these are the four muscles which come in relation to the anterolateral or the superficial surface of the thyroid gland. Next is the medial surface or the deep surface. If you see in the image here, this is the medial surface or the deep surface. This surface is related with a very easy way to remember is two tubes, two muscle and two nerves. The two tubes are larynx and trachea, pharynx and esophagus. Two muscles are the inferior constrictor muscle and the cricothyroid muscle. And two nerves are the external laryngeal nerve and the recurrent laryngeal nerve. So these are the relations of the medial surface. This recurrent laryngeal nerve then passes upward in the tracheoesophageal groove, and it usually lies behind the Berry's ligament, but sometimes it can even pass through it or even in front of the ligament. Next is the posterolateral surface. If you see in the image over here, this is the posterolateral surface. And as you can see it here, the posterolateral surface is related to the carotid sheath and its contents. This is the carotid sheath in relation with the posterolateral surface. Next, coming to the two borders. First is the anterior border. Now, the anterior border is the border which is separating the superficial surface from the medial surface. So, in this anterior border, what we are able to see is it is accompanied by the anterior descending branch of superior thyroid artery. That is the relation of the anterior border of the thyroid gland. Next is the posterior border. This border is separating the medial surface from the posterolateral surface. And this border has much more relations. The first one is it has a longitudinal anastomosis between the superior and the inferior thyroid arteries. If you see in the image over here, you're able to see this is the superior thyroid artery, and from below is the inferior thyroid artery that is coming. And they are anastomosing on the posterior border of the thyroid gland. Second relation is the parathyroid glands, as I've mentioned before. These parathyroid glands are related to the posterior border. As I've mentioned before, the parathyroid glands lie in between the true capsule and the false capsule of the thyroid gland. So here you can see again in the image the superior parathyroid gland and the inferior parathyroid gland. So these are the superior gland is located at the level of cricoid cartilage, and the inferior one lies close to the lower pole of the gland. And the third relation of the posterior border is the lower part of the border is related to thoracic duct on the left side. So these are all the parts of the lateral lobes of the thyroid gland. Next, let's discuss about the isthmus and what are its relations. So as we have seen before, isthmus is a connecting structure in the midline which is connecting both the lateral lobes. The dimensions of it is 1.25 centimeter in both vertical and transverse diameter. Coming to its relations, it is related anteriorly from within outwards by the sternothyroid muscle and the sternohyoid muscle, investing layer of the deep cervical fascia, anterior jugular vein, and superficial fascia and skin. It is related posteriorly with the second to fourth tracheal rings. The lower border of the isthmus, this is related to inferior thyroid veins and arteria thyroidea ima if it is present. And last of all is the upper border of the isthmus. This border is related to multiple things. First of all is the arterial anastomosis between the two superior thyroid arteries of both sides happen along this upper border. Second, sometimes a structure which is known as the pyramidal lobe arises from here. A pyramidal lobe is another one such short note that you sometimes get in your exams. What is pyramidal lobe? You can see in the image here, this is the pyramidal lobe. Now, what is the pyramidal lobe? Pyramidal lobe is basically an accessory part of the thyroid gland, which is not seen in all individuals. It is seen to be in 50 to 60% individuals. It usually extends upwards, and from the isthmus, it goes towards the hyoid bone. What is it exactly? It represents a distal remnant of the thyroglossal duct, and it can extend superiorly up to the level of the thyroid cartilage. Now, this apex that you see over here, it can sometimes get replaced by a fibrous or fibromuscular tissue. And in that case, this comes to be known as the levator of the thyroid gland. Now, what is the importance, clinical importance of pyramidal lobe? Identifying and removing this pyramidal lobe is very important part of thyroid lobectomy. Why? Because if you leave behind the pyramidal lobe, you'll actually end up leaving behind functional thyroid tissue. That is why you should be removing the pyramidal lobe as well. So whenever you're performing the surgery, you should also look out if there is a pyramidal lobe present or not. Next is another structure that is related to the upper border of the isthmus, and that is known as the tubercle of Zuckerkandl. This is again also a short note that you get in your theory exams. Now, what is tubercle of Zuckerkandl? It is basically thought to be representing the point of embryological fusion of the ultimobranchial body and the median and large. Here, what we see is basically, and if you see in the image over here, we see a lateral or a posterior projection of the thyroid lobe. And this is seen to be in only 60% of patients or individuals. It is not seen in all people. So, what is the importance of having this tubercle of Zuckerkandl? First of all, is we have to know that the recurrent laryngeal nerve most often runs medial to it. If you see in the image over here, this is the tubercle of Zuckerkandl, and medial to it, you can see that the recurrent laryngeal nerve is passing. Second, the superior parathyroid gland is usually attached to its cranial aspect. And third, when this gets enlarged as a part of goiter, it can inadvertently get left behind during subtotal thyroidectomy. So that's all about the pyramidal lobe and the tubercle of Zuckerkandl. Next, let's talk about the blood supply and lymphatic drainage of the thyroid gland. So first, let's talk about the arterial supply. So the main arterial supply includes the superior thyroid artery, inferior thyroid artery, arteria thyroidea, and numerous accessory thyroid arteries. First main one is the superior thyroid artery. Now, superior thyroid artery is a branch of the external carotid artery. You can see in the image over here, this is the external carotid artery, and that gives rise to superior thyroid artery. And this superior thyroid artery runs downwards and forwards in relation to the external laryngeal nerve. And we have already spoken about this relation in terms of the apex of the thyroid gland. And this gives off a branch to the adjacent structures at the upper pole. And then it divides into anterior and posterior branches. Now, the anterior branch, what it does is it descends on the anterior border of the lobe. If you see here in the image, the anterior branch descends along the anterior border, and it anastomoses with the opposite side branch at the level of the isthmus. Whereas the posterior branch, it descends on the posterior lobe of the thyroid, and it anastomoses with the inferior thyroid artery along the posterior border. So this is the superior thyroid artery. The second artery which supplies the thyroid is the inferior thyroid artery, which is a branch of the thyrocervical trunk of the subclavian artery. So if you see in the image here, this is the subclavian artery, and you can see it gives off a thyrocervical trunk, and the thyrocervical trunk gives off a branch which is the inferior thyroid artery. This artery runs upwards and then medially and then finally downwards, and it reaches the base of the thyroid gland. This artery is very intimately related to the recurrent laryngeal nerve at the base, which we have already discussed. And it gives off an ascending branch which anastomoses with the superior thyroid artery along the posterior border of the thyroid gland. Next artery is arteria thyroidea ema. Now, arteria thyroidea ema is not a branch that we are seeing in all individuals. It is only seen in 12% people, and it is usually present ascending in front of the trachea to supply the isthmus. This is usually a branch of the brachiocephalic trunk or the arch of aorta. You can see in the image over here, this is the brachiocephalic trunk. This gives rise to the arteria thyroidea ema, and it goes and supplies the isthmus of the thyroid gland. Last of all, there are numerous accessory thyroid arteries. These are all derived from esophageal and tracheal branches, and they supply the gland from the medial surface. Next, let's discuss the venous drainage of the thyroid gland. Now, the veins usually don't accompany the arteries in this case. These veins, they start arising from the venous plexus. Now, do you remember where the venous plexus lies? The venous plexus lies deep to the capsule of the thyroid gland. So, this venous plexus gives rise to all the veins, and they get drained by the superior, middle, and the inferior thyroid veins. Now, if you see in the image over here, first one is the superior thyroid vein. Superior thyroid vein emerges at the upper pole of the thyroid gland, and it accompanies the superior thyroid artery, and then it ends up in the internal jugular vein. Next, second one is the middle thyroid vein. You can see over here, this is the middle thyroid vein. This emerges at the middle of the lobe, and this also ends up in the internal jugular vein. Third one is the inferior thyroid vein. Now, inferior thyroid vein, they emerges from the lower border of the isthmus. You can see here, this is lower border of the isthmus gives rise to the inferior thyroid vein. An inferior thyroid vein is the one vein that does not drain into the internal jugular vein. Rather, it drains into the brachiocephalic veins, mostly of the left side. You can see over here in the image, this is the left brachiocephalic vein of the left brachiocephalic vein, and this is where the inferior thyroid veins drain into. Last of all is another vein which is known as Cocker's vein. Now, Cocker's vein is not present all the time, but sometimes this vein emerges from the lower pole. You can see over here, this is the Cocker's vein. It emerges from the lower pole and it drains into the internal jugular vein. So, this is about the venous drainage of the thyroid gland. Now let's talk about the lymphatic drainage of the thyroid gland. A thyroid gland has a very rich lymphatic network, and it drains into several different groups of nodes in the anterior and lateral neck. So let's divide it into two parts: lateral aspect of the gland and medial aspect of the gland. Now everything from the lateral aspect of the gland, they drain into the level 3 and the level 4 jugular nodes, and sometimes the level 5, which is the posterior triangle lymph nodes. Whereas the more medial aspect of the thyroid gland, they drain into the nodes of the anterior compartment of the neck, which is level 6. And from here, this in turn goes to drain into the upper anterior mediastinum nodes, which is level 7. So, this is the lymphatic drainage of the thyroid gland. Last of all is the nerve supply of thyroid gland. Now, nerve supply comes from both parasympathetic as well as sympathetic nerves. The parasympathetic supply comes from the vagus nerve, and sympathetic fibers are derived mostly from the middle cervical ganglion, but there's also contribution from the superior and inferior cervical ganglion. So there are two nerves which is very intimately related with the thyroid gland, and that is the recurrent laryngeal nerve and the superior laryngeal nerve. To learn more about these nerves, I have already made a separate video on it. Please check that out. And if you have any other question related to the thyroid anatomy, please note them down in the comment section and I'll get back to you. Thank you.